We have a healthcare cost problem in our country. There is no question about that. Healthcare is too expensive, costs are going up. But this bill doesn't do anything to address those underlying problems at all.
Hello, one and all, and welcome back to a brand new episode of The Real Impact. I'm Michelle Rathman, and we are thankful that you have carved out time from your very busy schedule to join us for another conversation that works hard to connect the dots between policy and rural everything. Well, today it's a big show because we are continuing our 2026 series we're calling Tracking Transformation. And in case you've not been following along, well, welcome. We're glad that you're here again. But simply put, we are following the flurry of activity resulting from last year's passage of H.R. 1, known first as the One Big Beautiful Bill Act, which, as you will hear if you have not heard this already, doesn't look pretty for rural anywhere you turn. And that is just a fact that needs to be said plain and simple. So if you don't believe me, the guests I have here today might convince you otherwise. Because for this conversation, I've invited back to the show one of my favorite people on the subject of health policy, and that is none other than Joan Alker. Joan is a research professor and executive director at the Georgetown University Center for Children and Families. And we are also joined by Dr. Shannon Dowler. Now, Dr. Dowler, who is not only a remarkable family physician, and you're going to hear about that in just a moment, she also serves on the board of directors for the American Academy of Family Physicians, and is a wicked smart health policy consultant who was immersed in the state of North Carolina's Medicaid expansion, which, if you recall, just took effect on December 1st, 2023, so not that long ago. And as of February 2nd, I went ahead and did the tracker, had a look at the North Carolina's tracker. As of this year, February 2nd, has given over 700,000 North Carolinians access to affordable healthcare coverage. So that is no small number. Now, I heard Joan and Dr. Dowler speak on a panel about RH1 and Medicaid cuts, and each of them will join me in just a few minutes to share their invaluable insights. Now, after a quick break and my conversation with those two, you're going to hear parts of just a few of the many conversations I had while I was in D.C. just a few weeks ago at the National Rural Health Association Policy Conference. I've shared with you before that I have the privilege of being a member of that organization, and I also sit on the Policy Congress. Really important work that they're doing to help advocate for better rural health policy. And that includes a conversation that I had with another phone a friend, Alan Morgan. And Alan is the CEO of the National Rural Health Association, of course, as well as my conversation with the association's 2026 president and the associate professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health, Carrie Henning Smith. And I just want to share with you, I read an interview that Carrie did as her incoming term, and this is something that she shared that I want to share with you. These are her words. This is a moment of incredible change and volatility, and it feels more important than ever to have a strong community where we can share ideas, support one another, and move policy, programs, and research forward in a way that truly has the best interest of rural and the voices of rural residents at its core. So remember that as we have these conversations that continue throughout the year as we track transformation. Again, it's another big episode here on The Real Impact. We are so glad you are here. So now it is that time that I invite you to sit back, tune out that background noise because it's going to be there after your time with me, and hear my conversation with Joan, Dr. Dowler, Alan, and Carrie. Are you ready? Here's my mug. Are you ready? I sure am. So let's just go. Dr. Shannon Dowler and Joan Alker, our trusted phone a friend. Joan, I really mean that for coming back to us. We are so grateful for you both for joining us here on The Real Impact. Welcome.
Thanks. We're excited to talk with you today.
Yeah, great to be here.
I know you both are so busy. So listen, as our listeners learned in our introduction, we are continuing our commitment to tracking rural health transformation. And of course, we are not going to talk about the $50 billion taxpayer fund established for this purpose. We are going to focus on the flip side of the coin, which is costly, to say the least, which is HR 1, specifically the impact of nearly a mere $1 trillion in cuts, or as they're saying, reductions into Medicaid coming out of the budget, and other policy shifts that were written into this law that will impact both patients and health professionals who care for them. So, Joan, I know you follow this so closely. I saw the two of you present at a panel just last week. This drops a week later at the National Rural Health Association Policy Institute, and it was a standing room only. I mean, like many people deep, because this subject is, I know there's a lot of other things going on, but this one is probably one of the most pressing in my lifetime, I think. So, Joan, I'm going to start with you because you have receipts, as they say. You really laid out for us what this means from the big picture perspective, HR 1's Medicaid cuts and the rural health equation. So let's focus on that. Let's refresh some of the numbers so our listeners who have not tuned in before really understand the implications here. Let's start with the Medicaid cuts in general and then cover the metro areas versus small.
Sure. So unfortunately, when last year the so-called One Big Beautiful Bill by President Trump passed, at the heart of this were a number of policies, including tax cuts, also including a tripling of the budget for ICE. And while the bill added to the deficit, there were concerns about looking like they were doing that, which they were. And they had essentially, the president had taken Medicare and Social Security off the table during the campaign. And that meant what we feared would be they'd be coming for Medicaid. Mm-hmm. And indeed they were. And we ended up with almost $1 trillion in Medicaid cuts. That is about 11% cut in Medicaid. So that's pretty big. And, I think one thing that's really important to understand here, and I think rural communities certainly get this, we have a healthcare cost problem in our country. There is no question about that. Healthcare is too expensive, costs are going up. But this bill doesn't do anything to address those underlying problems at all. In fact, it just takes money out of what is actually the lowest payer in the system, right? So the part of the system that is being the most cost effective, for better or for worse, mm-hmm. right? I mean, that's one of the strengths of Medicaid, that it is relatively lean, but that also can lead to access problems. And certainly for rural communities where we know that families and adults are more reliant on Medicaid for their health insurance in rural counties than they are in metro counties. And that's what a lot of our research has reinforced over the years, that these kind of cuts could be very devastating. And we can talk about some of those specifics in a moment, but that's the big picture.
Yeah, and I'm gonna go on a limb and say not can be, they will be. There's just no other part that I can parse this out to come up with a different number. I want to talk for a moment, Joan, before we move on, just about some of the data that you share about women in childbearing age with Medicaid coverage, because this is, again, to me, we say one thing, but then we do another. We're talking so much about the need to protect women and children, but what happens when you take away that coverage? Give us some of that. What's that big picture look like?
Yeah, so Medicaid is incredibly important for children across the country. The data is sort of complicated, but as many as half of children are covered by Medicaid, and they tend to be more likely to be covered in rural counties. Medicaid is also incredibly important for women of reproductive age, and especially for when they're pregnant. And so what we did some research looking at women of childbearing age, and we see that in states that have some large rural populations that have picked up the ACA Medicaid expansion, that, up to 40, 50%, some counties I know is higher, of those births are being paid for by Medicaid. In states like Louisiana was actually one of the top states, New Mexico, Kentucky, other states. And so this is incredibly important. And we know that we have a crisis in this country related to maternal health. And that's especially acute when you're talking about rural areas where, not only can you perhaps not get the prenatal care, but most importantly, there's nowhere safe to go within driving distance to deliver your baby. And unfortunately, there have already been instances, tragic story in Mississippi, which has not expanded Medicaid, but in any event, where a woman died on the side of the road because she was trying to get to a hospital and her husband was frantically calling 911. Now, this is a woman who had private insurance. It don't matter what insurance you have if there's nowhere to deliver your baby safely.
Yeah. Oh my gosh. And this story is not getting any better. I mean, and the walls feel like they're closing in because there's so many other competing kind of crises that are brewing. Before we move on, the last thing I want to ask you before we have Dr. Dowler join us here is, last week, and I said this, I did a little bit of a short, and I told our audience, some of the remarks I heard last week at this policy Congress literally blew my mind. We heard Dr. Oz and his remarks, of course, the head of CMS, that the $50 billion fund was the largest investment in rural health in our history. But in fact, your data, it does tell a different story because it just does. So let's just do a juxtapose of that. $50 billion and then all these cuts. I mean, we're not ahead.
That's right. And this is analysis by KFF that even if all of the money in the Rural Health Transformation Fund was an exact one-for-one replacement of the Medicaid dollars, which it's not going to be. There's actually a lot of limits in the Rural Health Transformation Fund in what rural hospitals can get, which is really kind of shocking to me, because a lot of the political pressure around this was because members were concerned about rural hospitals closing. Yet the Trump administration put in a 15% cap. That's not actually in the legislation. They added that when they gave out the money. So, but even so, it would be only accounting for a third of the losses that rural areas are expected to see. And remember, this is a 5-year fund. And the Medicaid cuts are, they're a 10-year window here, and they get worse as long as time goes on. So this is, I really, really hope that this provides some exciting advances for rural areas in the next few years. But this is in no way a long-term solution to the challenges that rural communities face. And I think, rural communities, just to say, I mean, the sort of big marquee policy here is the work reporting requirement. We can maybe talk about this later, but I think there are reasons for rural communities to be especially concerned about what's going to happen.
Yeah, that's a great point. And we are going to be starting to talk to county officials because, there is a domino effect here, and county budgets are going to, already stretched thin, are going to find themselves in quite a pickle. So, all right, Dr. Dowler, I'm so elated that you are with us. You have such a perspective that I dare say that many policymakers, even those who are physicians, do not have. And that is a family physician living in a rural community, serving a rural population that has historically been categorized as underserved. I say under-resourced. So before we dive into the policy piece, share more with us about your work, the patients you serve, and some of the most formidable challenges that you foresee as a result of HR 1. Tell us a little bit more about yourself first.
Well, always happy to talk about myself and to be with you guys again. It was great to meet you last week at the meeting. So I'm a family doctor, as you said. I've got over 20 years experience. My career has really been in the service to underserved populations. That's been sort of my guiding force as a family doctor. I'm currently providing HIV care in a federally qualified health center that serves 18 Western North Carolina counties.
Wow.
I also volunteer at a free clinic as well. And prior to my current situation, I spent 5 years as the chief medical officer for North Carolina Medicaid, where I really learned the Medicaid program in a different way. And I will say that proudly my last act before I departed the state was getting to help lead the Medicaid expansion work, which was a long time in coming, but it finally happened. I think when it comes down to the work requirements specifically, which targets that expansion population, it just doesn't promote the objectives of the Medicaid program. And there's really clear data that demonstrate that these very costly requirements, it's very expensive to implement them, actually don't have an impact on employment rates because most of our expansion population are already working. They're just in very low income jobs. And what it does is leads to higher cost and burden for states and employers by creating barriers to care. So really, these work requirements at the end of the day aren't good for anyone. The Medicaid programs at the state level have to implement these. And I mentioned it's costly. It's so nuanced, managing a Medicaid program. And if you don't do it well, the repercussions are significant. So you want to do it really well. So their states are going to have to implement these sort of vague guidelines all the way down to maybe the county level, depending on who is doing the enrollments in a community. Who's going to do that work? It's double the work that they had before. It's going to be very expensive, and everyone is, particularly in rural America, is struggling with workforce. So this is going to add burden at the community level just to implement them. And part of the problem is that these work requirements are targeting people who are already working. They're just working in very low income jobs. Sometimes they have to have 2 jobs at once to make ends meet. And so what's going to happen is people are going to fall out of coverage, and we'll see churn. So churn in our Medicaid language is people that fall on and off of care. When you're privately insured, that happens a little bit less often. Of course, once you're older, you get Medicare and you keep Medicare. But with Medicaid, people come in and out of care. And so this is going to really impact our offices, our clinics, our hospitals, our pharmacies, because people are going to walk in the door and expect care, and they're going to find out that they don't have coverage anymore. They may not even know that they fell off the books of Medicaid because they didn't understand that these work requirements were things they had to respond to, or maybe their address changed, or maybe they don't have access to internet. And I think that's an important piece of this. Not everybody in the world has the same health, written, digital literacy, and not everybody has access to broadband and devices and the things that you need if states decide to implement these work requirements through an attestation process or some sort of digital process. And even if there's a way that you could go into your county office, where I live in the middle of, on the side of a mountain, deep in the Appalachians, it's a 30-minute drive for me to get to a county office for the most part. So if you don't have access to ready transportation, or if you work during banking hours when those places are open, there's another barrier that's going to keep people from getting to stay on the books. And so what we'll see is unnecessary emergency room utilization go up. We'll see medical debt go up, and we'll see work absenteeism go up as well, because people will not be able to take care of themselves, and they're going to end up getting sicker.
Yeah.
So,
another part of this equation that I want to touch on really quick is that a big part of this also included the permissibility of legally present immigrants to have access to health care. And I had a conversation I mentioned with a federally qualified health clinic leader in our last episode. And she was talking to me about how already the impact they've seen on just people coming in and foregoing their care completely. So as a family physician, doesn't that seem to go against the entire philosophy of all this Make America Healthy Again notion, when we in fact are putting up so many new roadblocks for people to access care? And I wonder if you wouldn't mind just touching on that as well, and maybe what you're seeing early signs of this happening, and a little crystal ball of what you foresee in a very short period of time, I would imagine.
Yeah, I think you're right on. As a family doc, I want to take care of everybody that walks in my door and everyone that lives in my community. I really don't want to worry about who their payer is. We have to, because it's the world we live in. But as someone who's worked in federally qualified health centers and health departments for the majority of my career, for me as a physician, that part is not important to me. I just want to have a door that they can walk through safely and be cared for. And what we're seeing is that people don't feel safe coming in. Particularly, I notice this more actually in the urban center rather than is where I am super rural. When I'm in clinic in Asheville, people are not coming in. They're asking for telehealth visits. And these are people that are coming into us in the city from outside, from the rural areas, because they're afraid of coming into the denser population centers where they think that probably there will be more immigration resources deployed. And so I'm trying to get people to do telephone visits and telehealth visits as much as possible, so they can stay plugged into care and stay connected to care. But again, going back to what I was talking about earlier, this requires that they have digital literacy and digital access. And those are barriers that unfortunately not everybody has.
Yeah. Joan, you said earlier, that you're hopeful that, some good things will come of this. And so again, I feel personally, I'm such an optimistic person by nature. At this point, I'm digging deep to try and find some positivity where this is concerned. I do want to talk a little bit about provider tax restrictions because that is something that I think, because it's not something you're going to read about on social media, except for the policy wonks, who are paying attention. You're not going to see it on the evening news, certainly not now. But can you give our listeners a Cliff Notes version of what we need to be bracing for where this is concerned? And then, Shannon, anything that you've got to add, because you're included in this equation as well. I mean, your bread and butter, your ability to keep your lights on is affiliated with this little known thing called provider tax. So, Joan, give us a synopsis so that people really understand.
Sure. So Medicaid is a federal state share program. And so that means that states have to put up a share of the cost, and that depends on the state. But on average, the federal government's paying about 2/3 of the cost, but it depends on the state. And so states have to have revenues to put up their share, right? That's how states get money. They have taxes, okay? They have sales tax. They have fees when you get your driver's license. They have fees to register your car, helps them pay for roads, right? So states have all these ways of raising revenues that they have to do. And one of the very, very, very common ways to raise revenue for Medicaid, and every state in the country except for Alaska has done this, is what are called provider taxes. So these are taxes that are, nursing homes, hospitals, really any provider can be taxed through a provider tax. And this has been a really important source of revenue for states. So the bill does a number of things to clamp down on those. And over time, that'll get tougher for states. We talked about how, the long haul here is going to be even uglier. Mm-hmm. And in particular, states like North Carolina that have expanded Medicaid under the ACA. And a lot of this bill was really directed at, let's take 1,000 cuts on ACA Medicaid expansion. A lot of these same folks wanted to repeal the Affordable Care Act and they failed. And so now let's kind of come in through the back door and
death by 1,000 cuts.
Exactly. Mm-hmm. So these restrictions are going to be even tougher in states that have done the Medicaid expansion. So this is another way that it's a double whammy, right? Because there's cuts in the federal money. There are cuts to eligibility that are going to happen as a consequence, as Dr. Dowler talked about, people not meeting the work reporting requirement, not because they're not working, but because they don't get through the paperwork maze. Mm-hmm. And then this is a way to sort of restrict states' ability to raise their own funds to pull down the federal funds. So that has like a multiplier effect. So, this is a wonky topic, but it is very important. And it's all part of the squeeze here. And I'll just say, at the start of this process last year, the House Budget Committee wanted to block grant cap Medicaid, take away the entitlement and cut 1/3 of the program. And that would devastate the program as we know it. And there are people who want to do that. So, depending on what happens in the elections, I think we should expect to see that kind of proposal come back. It's very possible. So this is sort of a long-term plan to really squeeze Medicaid and end it as we know it.
Yeah, on your slide, I'm reading, the big hits will come to California, Illinois, the state I'm in, Massachusetts, Michigan, New York, Ohio, West Virginia, a different layer of hurt. And as I read this last bullet point, $225 billion over 10 years in spending cuts.
Yeah.
I mean, with no way to make up for that. It's just insane to me. I can't speak to the rationale behind it. I just know it makes no darn sense to me. Okay, I want to talk about something, and I'm going to continue to use this. I tell people you'll have to take the word out of my dead cold body before I stop, which is the term around health equity. You talk, Dr. Dowler, Shannon, about one of the topics that is very near and dear to your heart is that Medicaid historically has been a lever for health equity. H.R. 1 creates a barrier, is probably an understatement. How has this impacted you and your fellow physicians? I know you don't speak for all, but I wonder, what's the conversations you all are having in the rooms that we're not in?
Yeah, so I think I've got sort of two thoughts on that. One is tagging onto what Joan was just saying about the financial devastation that's coming to states around their Medicaid programs is they're going to have to cut services. And they can only cut optional services. And optional services are big things like dental care, medications, pharmacy is optional, physical therapy, occupational. So there's so many ways that states are going to have to just cut and eliminate and restrict access to care for people that it's going to hurt. And it's at the end of the day going to hurt the people who are receiving the care. And when you think about health equity, so the second part of this is I think of equity from a really broad perspective. I think about race and ethnicity, but I also think about economic disparity, geographic, rural versus urban, gender disparities, and age disparities. And in North Carolina, when we expanded Medicaid, we saw clearly, because we measured this from the beginning and we have a public-facing dashboard, there was a disproportionate positive impact on our rural populations. We enrolled more people benefited from Medicaid expansion that live rural as a percentage of our population than urban. And so unwinding that is going to create more health disparities. We already see worse outcomes in our rural communities. That is going to just get exacerbated again. I think the other place I think the disparities are going to really show up is around age inequities. And what we see is that a lot of the people that qualify for expansion are either childless adults or childless older adults that aren't quite ready to qualify for Medicare yet, but they're accumulating the health problems and the chronic disease that makes it really hard for them to get to work and stay healthy. And so once we expanded, we saw all of these people that weren't quite Medicare eligible yet. They're not disabled. They're still in the workforce. They were suddenly able to get some support, paying for their insulin or their other high-cost medicines or seeing specialists that they neglected to see to take care of their chronic diseases. And so we're going to see that population of people lose coverage again, potentially, or at least have their benefits limited. Because at the end of the day, we're going to take benefits away from the pregnant women and children last, most likely, which is, I mean, that's probably if I were still the CMO of Medicaid, I would be thinking about it that way too. But it's really going to hurt this other working population that are in that sort of pre-Medicare population where they're old enough to be sick and to really have health problems, but not make enough money to be able to afford marketplace insurance or other insurance. And so we're going to see their outcomes get a lot worse.
I think your state is going to be a really interesting one to watch because you were just starting to be able to measure some of the gains that you made. We actually interviewed Maggie Sauer from the North Carolina Office of Rural Health when you guys did your expansion a couple of years ago at another policy conference, and everyone was cheering about it. And so you just be able to start to see some of those gaps close, and now you're going to watch them widen. So we have to pay attention to that. Okay, I wish we could have so many more things I want to talk to you about, but before I let you go, as we always do, I mean, this podcast is all about policy and connecting the dots between policy and rural quality of life. You know, we've got policymakers listening, we hope. If not, we're going to, put a little bug in their ear, but we've got a lot of advocates out there listening as well. What is the conversation that we need to be having with them? What message do we have from them? Because we cannot put the toothpaste back in the tube. How do we advocate to mitigate some of these harms of these Medicaid cuts? Joan, I know you at Georgetown, you guys are doing so much research and you're putting out the data. What does it matter if no one's listening? So how can we compel people to not say, well, there's nothing we can do about it? Because we must. Not doing something is not an option in my book.
Mm-hmm. Yeah. I mean, I'd say two things. I mean, I think of the big picture, no state, no matter how rich or how well-intentioned, is going to make up for these federal cuts. So ultimately, we have to get Congress to reverse the cuts, right? And that's the big picture message. Elections coming up, and Medicaid is very popular with the voters, I'll just say. That was, oftentimes you see this where legislators are out of step with the voters. And we absolutely saw that. I think last year, Medicaid cuts were not popular with Republicans, Democrats, or independents. And the president's own pollster told them that.
And they did it anyway.
They did it anyway, but they're trying very hard not to talk about it. They deny there are any cuts, and we're going to hear about Medicaid fraud from now until the election, so that the conversation has shifted. So we got to keep our eye on the ball to highlight how important Medicaid is for rural communities, all communities in this country. And ultimately, Congress is going to have to reverse the cuts. However, in the short term, I think it's critically important for rural communities to work together, providers, schools, churches, to educate themselves about what's coming down the pike. Because this, in particular, this work requirement that's coming in January 1st, 2027, that's not far away. And there are all these exemptions, right? But are people going to know about them? Is the system going to work to give it to them, right? So there's a lot of education that has to happen here to minimize the coverage loss.
Yeah, that's great. Physicians are neutral conveners in many ways. I've been working in this field, people know, for many, many years. So as a physician, where do you see your abilities, less of a role, but your abilities to elevate the conversation and educate people on the things that we're talking about here today?
Well, we've seen, at least speaking for family physicians, over the last couple of years, more and more involvement in policy and reaching out to legislators to say, hey, this doesn't make sense. We have a meeting every year, the Family Medicine Advocacy Summit up in DC. And we had the highest attendance last year in the history of doing it. So we're seeing people get more excited. I will tell you, as someone, I only spend 1 day a week in clinic right now, and it is exhausting. I was up till almost 10 o'clock last night, finishing my charts from the patients I saw yesterday. So physicians that are full-time doing this in clinic, I just don't know how they would have the bandwidth to do much more, but we've got to get them thinking about it. One of the things I would say is that we've got to reverse this belief that I think is being put out there by the administration very intentionally, that these rural health transformation dollars are somehow a fix for HR1. They're completely unrelated, and they in no way equal each other. And so I think we have to be really clear about dividing that out. And then I will say, after 5 years at the state, working in the Medicaid space, there is definitely fraud, waste, and abuse. I have no doubt it is. From my experience, whether it's from my lived experience in rural Appalachia or all the way to my seat at state government, it's not happening with the average person. Fraud, waste, and abuse is not happening with the people that the administration really seems to think that it's happening with. There are so many ways we can reduce waste in our healthcare system right now and save dollars. Implementing work requirements at the tune of hundreds of millions of dollars is probably one of the biggest waste cases I've ever heard of in my career. So how can we work smarter to find money, to save money from the program and help everybody end up, being happier at the end of the day?
Yeah, I appreciate that. And listen, to all of you, disinformation and misinformation is winning the day. And the reason why these narratives are so popular is because they are elevating people's algorithms. So when you hear something that is inaccurate, it might be easier to walk away and say, I can't even. What's harder and more fruitful, I think, is to make sure that rather than, not tell someone they're wrong, but present them with the correct information and then guide them to resources like the two of you have to make sure that people are well-informed versus misinformed. So, oh my gosh, before we let you go, Joan, where can people follow you? Because they must follow your work.
Well, visit our website, which is ccf.georgetown.edu, and we have a weekly newsletter. I am on a lot of platforms, Blue Sky, X, LinkedIn, but come visit our website. We have a lot of state data too, and we have a whole rural health project with a lot of data there as well.
Excellent. And we'll make sure that goes into all of our show notes, and on our resource page, you'll be able to link right through and not even have to remember anything. And where can people, because your work, Dr. Dowler, we have to have you back because you've got another whole chapter I want to talk about. Where can they follow you?
Well, so I would say from the broad policy, what are family doctors thinking about? AAFP.org or familydoctor.org are great resources. For me personally, ShannonDowlerMD.com is my website, which I update every now and then. I am also on all the socials, and boring that, you can find me hanging out with my goats on the side of the mountain up here in Madison County.
I want to come hang out with you and your goats. You heard that here. Oh my gosh. Joan and Shannon, I really mean it from the bottom, in the middle of and top of my heart. Thank you so much for your time today. You both are so busy. So welcome back. Anytime that you have something new to share, there's a seat at the table for you.
Well,
Thank you
thanks,
so
Michelle.
much.
Okay, well, we have to say goodbye to our two great guests. You stay tuned because we have more of this dot connecting conversation from my time in DC. Next year, we're going to hear from Alan Morgan, CEO of the National Rural Health Association, and the 2026 president of that same organization, Carrie Henning Smith, associate professor of University of Minnesota School of Public Health. We will be right back. Stay tuned.
The Rural Impact is on the rise. Thousands of subscribers and listeners, hundreds of downloads per episode, a growing community of influencers united by a shared commitment to lifting rural communities. We focus on sound policies that improve quality of life for more than 60 million people who call rural America home. This is your invitation to be part of the rural movement, because your involvement can help shape real progress and lasting success. Explore our partnership opportunities and discover how we help expand your rural reach while sharing your rural impact. Visit theruralimpact.com to download our partner prospectus.
Or email partnerships@theruralimpact.com to schedule a time to talk with us.
Are you ready? Let's go.
We are back, and as promised, to round out this installment in our Tracking Transformation series, I want to share with you just a few excerpts from the many conversations I had while in DC attending the National Rural Health Association Policy Institute, which was in mid-February. This is an annual trek that I do every year and have been doing for many, many years. And this year, as you can imagine, there were a few topics that dominated all of the conversations. So after a very busy morning hearing from leaders at HRSA, HHS, members of Congress, as well as the Department of Veterans Affairs and the administrator of the Centers for Medicare and Medicaid himself, Dr. Mehmet Oz, who shared with a standing room only group of rural health leaders that there were no cuts to Medicaid. And that is a direct quote. So shortly after his remarks, I had the opportunity to sit down with Alan Morgan, NRHA's longtime CEO, and we discussed a wide range of pressing policy matters, including the organization's position on the explicit Medicaid cuts written into law in July of 2025. And of course, you heard me say that before, that is HR 1, in case you are looking for a reference. So after we hear from Alan, of course, I'm so grateful for him, but we also were very fortunate to nab a few minutes with the association's new president, Carrie Henning Smith, although she is a well-known, long-time rural health leader. And Carrie and I also discussed critical policy priorities, and she shared a few of her thoughts on what she hopes to see in action this year. So first, you're going to hear from Alan and then Carrie.
Yeah, and Michelle, what you're referencing is earlier on a program, Dr. Oz said these are not cuts. These are actually slowing the growth of the program. Tomato. At the end of the day, these are reductions in funding that would come to providers. And I firmly stand by the data on this, Michelle, that hospitals are closing because they have a disproportionate share of patients with high health needs and inability to pay. Period. They're not closing because of low volume. They're not closing because of bad management. It's this clustering of a population and then expecting the providers to pay for it. Medicaid is a state federal program dedicated to laser address this issue. And until we get another mechanism to address bad debt, this is the best tool we have to keep the doors open. So we disagree with the administration on this. Every rural hospital disagrees with the administration on this. These are cuts, and they have to be postponed going.
In many ways, I think the policy priorities remain what they always have been, and that's about strengthening the foundation of rural health and addressing rural health disparities that are so longstanding that require sound policy, as you say. But there are some immediate issues that require attention. First and foremost, I don't think we can talk about rural health without talking about the looming Medicaid cut. And so anything we can do to delay or hopefully stop those cuts altogether is critically important for rural health. We also need to continue to strengthen the safety net. We need a policy to focus on workforce. We have all of these
measures that have been put in place temporarily. And so we need statutory action to make sure that those can continue longer term. I'm thinking of the CDC Office of Rural Health. I'm thinking of the Flex program, all of these programs that are critically important for understanding what's happening in rural and strengthening what's happening in rural going forward. And so those are the association's priorities. Those are really things that I hope I see real action on as president this year.
Yeah. Thanks to everyone who spent time with me in DC. In a future Tracking Transformation episode, I really do hope that I'm able to bring you a few more voices we heard from the National Association of Community Health Centers, because I also went to their annual Policies and Issues Forum, where I discussed with some members some movements in the delivery of healthcare on wheels for rural, which is through the well-equipped mobile health clinics. So a wave of the future. Stay tuned for that, a couple of those conversations at a future time. But for now, let me once again thank Joan, Dr. Dowler, Carrie, and Ellen for their insights into these not so light subjects. Because as we say often, all roads to quality of life are paved by policy. We're going to keep having these conversations. Okay, we're going to keep these issues front and center. Coming up, we are going to be shifting gears because we're going to bring you the latest on rural education policy. There is a lot happening in that space. And we're also working on an episode that delivers straight talk on policy shifts for the United States Postal Service, the impact on rural economies, access, and elections. Okay, we're also going to be working on an episode that brings you the latest on the Farm Bill movements and so much more. Now, as a reminder, the content that we bring to you is made possible through our sponsoring partners and supporters like you. Every donation is appreciated. And now, when you make a purchase from our well-stocked merch space that you can find on theruralimpact.com, you can not only wear your support on your sleeve, you can wear it on your hat, carry it as a tote. You have a look at the store and see what you think. We'd love to see you take pictures of yourself wearing our gear. Quite frankly, that would be fun for me personally. To Bria Corsaro and Sarah Garvin for all you do, I thank you. To the rest of you, be sure to follow us on social, mostly LinkedIn and Blue Sky. You can also find us on Facebook as well. And finally, to all of you, this is a heartfelt invitation. These are some very challenging times that we are walking through together. So with that, a sincere invitation for you to take the best possible care of yourself and to the best of your ability, all those around you. We will see you again on a brand new episode of The Rural Impact.